Perfect. Okay, so this is Zoe Walker. She's going to be your guide for the next 3.5 weeks of mental health nursing. So I'm going to leave the session and leave it all to Zoe, if nobody has any questions for me.
Are you able to see me? You asked if my camera was on.
Yep, I can see you and we can hear you. So
okay.
You're working. All righty. See you guys next week.
Hi, Pam. Good morning, Zoe.
Good morning, everyone. I know Pam left me to you guys.
Good morning.
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 Quite a bit of people in the class. What's that? 34, 35, 6, 7, 8? Oh, wow. Well, it doesn't make a difference. I don't see anyone anyway. It's kind of weird talking to a screen, I can tell you guys that much. So my name is Zoe Walker. I'm a psych. Is someone recording? Anyone hit record? Let me see. Oh, it's recording. Someone did. Yep. So my name is Zoe Walker. I'm a psych nurse practitioner. I started out as an LPN. Then I went to Goodwin, did my RN. And I went to St. Joe's, did my APRN. And here I am today. So I can totally empathize with you. I know where you are. I know how it was. I think I know how it feels. I was in that very same class, taking this very same course at one point. I enjoy mental health. It is, for some people, it's kind of abstract. But for me, I find it totally exciting. It's what I do. It's what I love. Does anyone work in mental health right now? No?
No.
Okay. Does anyone plan to get into mental health when they're done with schooling? I see a couple yeses. Okay. Quite a few yeses. 3. Not sure yet. Four? I'm sorry, go ahead.
I had my share of mental health.
I'm sorry, I didn't hear you. Who's speaking?
Oh, forgive me. Go ahead, whoever was talking.
I said I work with psych and dementia.
Okay.
I have
For those people, you have one?
I have one dementia patient that I'm dealing with, and I had enough of mental health, so I don't know if I'll go back down that route.
I know mental health can be pretty exhausting, working in mental health. I can honestly agree with that.
Yes.
I can totally agree with that. But for those of you who remain uncertain, I can definitely share with you that no matter where you work, acute care, long-term, outpatient, inpatient, no matter what it is, you will encounter mental health patients. Because mental health is pretty common and a lot of patients have mental health issues. So let's dive into it. Before I proceed, I should tell you that they're doing my roof and I can hear them. So if you hear hammering background noise, that's what it is. Hopefully it doesn't get in the way of us getting class done. It is a lot of content to be covered today. I will give frequent breaks, but we usually get it done in good timing. So it begins with an assessment. So how do you begin by assessing your mental health patient? It is pretty much the same way you would assess your medical patient. You would get a mental status exam, definitely, but we kind of work our way up to it. So you're probably saying, if I'm not working in the mental health setting, then when would I be required to assess a mental health patient? But say you're working in a local hospital, a patient comes in and they're complaining of, say, something as mundane as a stomach. And then going over to assess the patient for the stomach ache, you notice this patient has this sad, sullen look on their face. They're barely talking. You ask, are you okay? And they go like, no, I've been feeling really sad lately, maybe even depressed. And voila, that opens up the door to a mental health assessment along with your medical assessment. So you want to ask the patient about their chief complaint. Is the chief complaint the stomach ache? Probably is. But then they're mentioning that they're depressed. How long have you been feeling depressed? When did these symptoms start? Can you tell me about your depression? Did anything happen prior to you feeling depressed? You want to decide, you want to determine if there's any precipitating factors, any triggers. Is there a period where your depression improved? You want to find out if anything alleviated the symptom. Maybe it's something going on at home. Maybe it's a child that had a discord with their parent or a loved one or something. So you want to explore this complaint a little further. Then you get into the patient's social history. This is looking at their roles, their relationships. Is this a single mother who is struggling to care for her children? Is this a child who's living at home with mom and dad and is well cared for and protected? Is this someone who is educated and has had various mental health treatment throughout the years? Does this person have a job? Do they have somewhere to live? Are they homeless on the streets? You want to look at all these different issues that could compound the presenting issue that you're seeing. You go even as far as into their developmental history. So yes, it began as a medical, or you could be working on the psych 4 and you're asking this psych assessment. Were you full term? Did you have any developmental issues growing up? Were you ever diagnosed with having learning disabilities? Did you have any difficulties in school, ever suspended, expelled? Because you want to get an idea of who this person is, an idea of their character, who they are. You go even deeper into their family history. So this person is coming in and they're saying, I'm depressed. Does anyone in your family have any mental health issues? And they go on to say, oh yeah, my sister is bipolar and my mom has a major depressive disorder. So that kind of tells you that you're likely looking at more than just a run-of-the-mill, I'm sad, I'm feeling depressed. There's probably something else going on. You want to, and as you went into their history, you ask about any previous psych history. Do you have a diagnosis of depression, any anxiety, anything in your past? Is this something that's recurring? Of importance too is looking at the patient's evaluation of themselves. How do they see themselves? What are their strengths? You'll have the patient that tell you, oh, I can kick this. I just need to do this. I need to do that. And once I do this, I'll be fine. There's a patient that tells you, I can't do this. This is too much for me. I'm kind of hopeless here. So you want to know their strengths, their hobbies. Do they have any areas of pride? And what do you think I mean by areas of pride?
Things that they're passionate about, like their family, maybe,
Their
or
family.
things that they're defensive about.
Yes, their kids, their accomplishments. I graduated college. I work as a nurse. They're proud of themselves. They're proud of who they are. It gives them purpose. Makes them feel better. Certainly does. You want to look at their coping. Ask them, have you ever felt like this in the past? When you feel sad or depressed, can you tell me some things that you do on your own to try to improve your mood? So you're kind of looking at their coping mechanisms as well, because that will play a huge factor into how this person works through the present symptom. Is culture, religion, or spirituality a factor? Is this person from a culture where they're able to show their depressive symptoms? Are they able to talk about it? Can they even say they're depressed? Because different cultures address mental health very differently. I already mentioned past psych history. Look at their medical history. Does this patient have a chronic health condition? Do they have stage 4 cancer? Are they home and hospice? There could be several factors playing into the patient's current mood, symptoms, and or ability to cope. So you want to make sure you're exploring every avenue. Ask about sleep. How have you been sleeping? And this is one question I ask my patients every single time we engage. How is your sleep? Because very often when patients are not sleeping, it gives you some insight that something else is going on. How often have you had an exam the next day and you're unable to sleep? I can speak for myself and I can tell you it happens pretty often. How often has something been on your mind? you're unhappy about something, you had a fallout with your significant other, you're up all night thinking about it because your mind is not at ease. So you want to ask the patient about sleep. Also of importance is asking about substance use. Is this patient presenting to you saying they're sad because they just use a sedative? Is this person presenting as sullen or depressed because they just consumed alcohol? So you want to ask about substance use as well. And yes, some medications, as I mentioned, like sedatives, does affect the patient's mental health. So you want to make sure you're getting a full picture, not just, I'm feeling depressed. You want to go back into their past, look at their current activities, and see if you can get a good picture, as in what is going on here or what is presenting to me. Any questions?
No.
No?
I have a quick question.
Yes.
So you're giving your example, when a patient comes in, if they are complaining about a stomach ache, and then we dive deeper and we're able to assess all these things, are we bound by like a certain number of a time limit to gather all of this, or just kind of whatever it takes? Because I know sometimes, we'll have multiple patients, we'll be in and out of rooms. And so just trying to gauge, how long a mental health assessment, aside from all the other information we'll be collecting, would take.
Okay, so you probably won't go totally in-depth gathering everything, but you want to ask these questions to see, is this somebody who we need to refer to psych? Do we need a psych consult? So is there a time frame on assessing a patient when you're working on the floor? Not necessarily. You want to make sure you're doing due diligence. Is this person presenting as sad? They're saying they're depressed. Do they have suicidal thoughts? You want to make sure you are asking all the questions to get the answers that you're looking for. Is this person saying, I'm feeling sad, depressed, but I'm taking medications for it? Oh, but I missed my medications for the past week. So you want to make sure you're asking all these back questions. I can't say for certain there's a time limit on it. I would say just make sure you're doing due diligence and asking the amount of questions to have a fair assessment where you can make a good judgment. Does that answer your question, Shirley?
That was me, that was Bisha, but yes, it does.
Okay, sorry, I thought it was Shirley.
Okay.
So someone mentioned that we would have to do a mental status exam. Most certainly. So when you approach this patient, mental status exam begins by looking at the patient's appearance. What are some things that you could notice in a patient's appearance that could be of concern as it relates to their mentation?
How they look, how they present.
Their wardrobe, just kind of how they present themselves.
Yeah. Their hygiene.
Their affect.
Are they odorous? Are they disheveled? Are they dressed for the winter in the middle of August? Their affect, and we will definitely get to affect as we go down to list. An affect it's the outward expression of your emotions. So are they telling you everything is okay, but you can look at their face and they look blunted or flat? Or are they giving you an inappropriate affect? They're telling you they just had a car accident and they broke their arm and they're laughing. Oh, I just broke my arm. It hurts like crazy. You're like, oh, what's going on here? So that's their affect. That would be inappropriate affect. You're looking at their behaviors. Are they pacing? Are they making fists? Are they irritable? Are they shaking? So this is all objective data you're gathering even before you start asking these questions. And as you start asking your questions, you're examining their thought processes. Is this person saying they're having suicidal ideation? Do they have intentions? Do they have plans? Are they voicing any phobias, any paranoia, any obsessions? You want to also look at their insight and judgment. And that is, do they understand what is going on with them? Do they understand that they have a diagnosis of depression, or do they realize that they have a diagnosis of schizophrenia? Do they understand the importance of taking the meds daily? Do they understand the importance of not using drugs and alcohol? So you want to look at their insight and their ability to make good judgment. Is this the person that came in to the ER or on your floor and told you they took the weeks for the pills yesterday because they felt really anxious, so they took everything thinking it would work? Or they took the weeks for the pill because they were attempting suicide? So there's so many different avenues this assessment could take, and that's why you want to make sure you take the time to ask these questions. And there's a mnemonic here: all bad subjects are tough, troubled characters, and that's the ABS, and it goes down with the first letters listed there. So that's your mental status exam. So along with doing your interview for your subjective data, you will do your objective information gathering as well. And to assist you in finding out exactly what is going on, there are standardized screening tools that are in place to help with assessing patients. Is anyone familiar with any of those listed on the slide?
Spoken about the Glasgow Coma Scale.
Okay. And if anyone has children, sometimes you'll take, well, very often when you take your kids to like their annuals, usually when they hit like the teen years, the pediatrician or the nurse will give them like a little questionnaire and tell them you fill this out. And it's usually like the PHQ-9 or the GAD-7 that they fill out. PHQ-9 is an assessment, is a screening tool for depression. GAD-7 is a screening tool for anxiety. So it just depends on where you work. Different places choose to use different screening tools. But very often a patient will tell you, and sometimes these are just standardized, you're just given sometimes to every patient. So the patient will come in for that stomach ache, and in your assessment you ask them to complete the PHQ-9, and when you look at the results, it says this patient has severe depression. So while they didn't voice that they were depressed, the screening tool brought it up that they were severely depressed, and then that will take you into an assessment for the psychiatric symptom that's presented. You want to make sure you always assess suicidality. A patient mentions to you that I'm having thoughts of suicide. It's a question I ask every single day to every single patient. And it offends some people that you ask, so they're like, what, you think I'm crazy? Why would I want to kill myself? And I have to ensure them that this is the question I ask of everyone. Are you having any thoughts of suicide? Sometimes the answer is no. Sometimes the answer is yes. Should the answer be yes? Do you have a plan? Sometimes, oh no, I've been suicidal my whole life. I always think about it, but I've never acted on it. Sometimes the answer is, like last week, I had a young 25-year-old patient. She goes, yes. I'm like, what is your plan? She said, I'm going to take all my pills or I'm going to hang myself. So my next question is, do you have intent? Do you plan on doing this? She goes, well, maybe not today because I'm going to work. What do you do for work? I work as a babysitter. But, so if not today, when do you think you'll? She goes, oh, maybe when I get off work or tomorrow. I've just been really down lately and I don't see the point in living. So this is a patient with suicidal ideation, with a plan, and with intent. So is this the patient that I say to, well, I hope you don't follow through on it or reach out to me later if you think about doing it? Is that the way to address this?
No. I think it needs immediate.
Not at all. Sorry?
I think she needs some counseling, a lot of counseling.
Yeah. So not immediate one-to-one. So I'm working from home. I've been working from home since March, which further compounds the issue because I am here and she is somewhere else. And she's refusing to give me her location. Because if I had her location, I could send crisis to her, we could send emergency services to her. So she's refusing to give up her location. She's refusing to contract for safety with me. So I reach out to our crisis team in my office and they reach out to her. Thankfully, she picked up. They were able to get her in touch with her therapist. She had been on a therapy for a few weeks. We got her in a therapy session the same day. And what was even of more concern is that this is a patient that had already attempted suicide like 3 times prior. So you're looking at ideations, plan, intent, history of attempts, and those are all red flags that this patient will most likely make an attempt. So immediate action is needed. If I was in the office and she was there in front of me, I probably would have sent her out via emergency services. The next slide just talks about assessing for suicidality. It mentions checking to see if the patient has social support. Social support is very important because if this is the patient that's telling you, I'm alone, there's no one for me to talk to, there's no one I can depend on, that tells you this patient has a lot weighing on them. Lethality. This patient had told me, I spoke to her last week, that, yeah, Zoe, I'm going to kill myself. I'll probably just eat a box of crayons. I'm like, okay. While she does have the plan, how lethal is it? I still would have followed through by having her being assessed by emergency services and such, because she does have active suicidal ideations. But while it's not lethal, she still needs to be assessed more in depth. So that's why I pass her over to the crisis team. Want to look at access. What if she told me I plan to jump off the Eiffel Tower? Okay, so it's going to take a little bit of planning to purchase your plane ticket, make your way all the way to the Eiffel Tower to climb up there and to jump off. So it's not quite immediate. You want to look at their access as against her telling me I'm going to hang myself. What is the possibility of her getting a hold of a rope, of a belt, or something to carry through with that plan? It's very likely. And I mentioned before also any plans or previous attempts, or is there a family history of? Is this the patient who's going to tell you I'm suicidal? Do you know anyone that has committed suicide, like a close friend or family member, is the question I usually ask. And they'll be like, oh yeah, my sister committed suicide. And that is of importance because that patient probably views this as a way out. It's a poor coping mechanism, and they may choose to emulate this behavior. So you want to know about family history of suicide as well. Here's another mnemonic for assessing suicidality. Again, ideation, substance use, so they have a purpose for living. Anxiety, trapped feelings, feelings of hopelessness. Are they withdrawing? Do they have anger, rage, engaging in reckless behavior? Any mood changes? So these are all things we look at when we're assessing one's ability to engage in suicidal activity. Any questions? So I am a fast talker. So if at any point you didn't catch something or I'm going too fast, please feel free to ask me to slow down. Okay?
Sorry, could I ask a question?
Yes.
Sorry, could you, you just gave the mnemonic for assess suicidality. I don't see that on the slide. Could you say it again?
The SLAP one, you don't have SLAP?
That's right.
Social support, lethality, access plan. Plan and previous attempt. Do you have that one?
Previous attempt. Okay, thank you.
Okay. And there's another one, is path warm, which is ideation, substance use, purpose. Are they anxious? Do they have trapped feelings? Are they hopeless? Are they withdrawing? Do they have anger, reckless behavior, or dramatic mood changes?
I don't see those. Are they listed on a particular PowerPoint? Because I don't see those.
No, not everything is listed on the PowerPoint. Someone said slide 6.
Oh, okay, I see it. I thought it was listed out differently. Okay, I have it.
So your predecessors have made it not so fun for you. I used to put every single thing on my PowerPoints. And then when I just started, Pam told me, don't put everything on your PowerPoints. I was a student and I got tired of writing. So I figured I'd put it all there for you. And then I'd get complaints that everything was on our slides. The PAM says, see, I told you, so I took stuff off, so not everything is on the PowerPoints. But I did add a lot more since we've been virtual, so a lot more information should be there. No, unfortunately, Erin, that beeping is my smoke detector, which I've changed the battery several times. And I'm waiting for an electrician to come and take a look at it. I can't get it to stop, unfortunately. Not a problem. It's driving me crazy too. I sit here to work all day. Just imagine me listening to that. Which foundation PowerPoint?
Yeah, I feel like
What slide are you referring to?
so I have unit 1 and then that goes into slides 1 through 6 and then it says legal and ethical issues unit 2.
Yes, we're on to unit 2.
Okay.
Legal and ethical issues?
Yes.
Okay. So legal and ethical issues is of importance with every patient that you encounter. But it becomes of even more importance when working with mental health patients because the lines tend to get a lot more blurred because the patient is deemed crazy. They can't think for themselves. They can't make decisions for themselves. So someone takes it upon themselves to make decisions for those patients. It's very important to remember that even though the patients are afflicted with mental health conditions, sometimes they may even be psychotic and don't have good thought processes. It is important for us to remember that they still maintain the same civil rights as any other patient, any other citizen. As nurses, one of our main goals is to understand and protect the rights of the patient. It's still important to have informed consent for these patients. So if it's a procedure that you would have received informed consent for from any patient and you're thinking, oh, he doesn't know that I'm doing this anyway, let me just go ahead and do it. It's not good practice, it's an appropriate practice. And we should always strive to do things the right way, even if the patient is deemed incompetent in our eyes. Like any other patient, this patient deserves a written plan of care or treatment plan. Collaboration is very, very important. I can tell you how often, very often my patients will go to the hospital and they will be inpatient for a while. They'll be inpatient for a while. They would have had their med changes. And because no one in the acute care setting took the time to follow through with their outside provider to let us know the patient was inpatient, they had med changes. This patient follows up with me in a week or 2 after discharge, and I would not have known that they had this inpatient stay and or that they had med changes. So collaboration is very, very important because sometimes the patients will go, say you're working in a hospital, they go to the hospitalized settings and medication changes would be made and they don't like the changes. So they will not necessarily come back to me and say, oh, when I was at Hartford Hospital or when I was at St. Francis, this change was made. Interpretive services. So you're thinking, or it's a thought that, oh, this patient is crazy, I don't need to get an interpreter in here, they don't know what I'm saying anyway. Absolutely inappropriate. This patient still deserves the same treatment you would have offered to any other patient. Make sure the care you're providing is with respect, dignity, and it is non-discriminatory. And I say this because in psych, the lines get blurred pretty easily. This patient may be very odorous. They may be very disheveled. You may have to put the blood pressure cuff on, and their skin, you can see the dirt on their skin. You're not allowed to squirm or make that face. You should still provide the same service to this patient as you would any other patient. This patient should be free from harm, as well as having the least restrictive care. So if this is the patient who you went to see yesterday and they hurl something from their nightstand at you, and you say to the CNA, you know what? Put restraints on Mr. Jones. 4 points. Strap him to the bed because you don't want to get something thrown at you. That is inappropriate. How about you seek to remove the stuff from his room that he can throw about? But at least he has freedom of movement. Advanced directives are important. You want to look at the legal ramifications of your actions, and this is why you make sure you follow proper protocols in caring for any patient, including mental health patients, because some of the actions you do can be unlawful. I just mentioned you directing the CNA to put restraints on a patient. That could be transferred into battery, or you could threaten the patient. You keep it up and I'll be there to put some restraints on you. That could be assault. Another wrongdoing that can happen in the mental health setting or in the hospitalized setting could be that of a tort. It's a wrongdoing against a person or their belongings. It can occur in any setting, but particularly in the mental health setting, owing to the likelihood of violence and challenging behaviors. Sometimes you will find yourselves working in places where you're new and the seasoned staff engage in some activities, and those are activities they use to control the patients, and it works. It makes for an easy shift, but you have to ask yourself, is this appropriate practice? Is this the right way to handle these behaviors? Am I engaging in something that could have legal ramifications?
Hey Zoe,
Yes.
are you able to go over the definition of tort again? I didn't quite catch that.
It's a civil wrongdoing.
Mhm.
It is a wrongdoing against a person or their belongings.
Okay, thank you.
Welcome. Nice to see a face. So we're going to look at ethical principles, and these are principles I'm sure you started way back when you just started nursing. So these are things that are not new to you, but it still remains pertinent even at the end of your nursing education. Non-maleficence, your duty to avoid harm. Utilitarianism, make sure the right act is the one that produces the greatest good for the greatest number of people. Beneficence, your duty to prevent harm and promote good. Justice, fidelity, veracity, your duty to be fair, to be faithful to your patients, to be truthful to your patients, and most importantly, to give your patients autonomy. So you have a med pass at 8 a.m. and Mr. Jones gives you a flight every single day because he chooses to get up at 8:45 and ask you to come back to give that med at 9. You have that hour window. Can you allow Mr. Jones that extra hour? Can you allow him to be autonomous and say, can I get up another 40 minutes later? You are directed to administer a med. The patient says, I don't want the med. Does the patient have the autonomy to make that decision? Do they have the right? So, did I hear an answer?
Yes, they do have a right to refuse.
Yes, they do. And in psych, it becomes even blurred because you know if Mr. Jones doesn't take that med in the morning, you know what kind of shift you're going to have. So are you going to force him to take it? You can't. You shouldn't. While you can educate him and say these are the reasons why you should take it, you can probably make another attempt after he has slept in and try again later. But remember, the patients still maintain their rights. So we're going to look at different types of mental health admissions. It could be voluntary. Sometimes I'll have patients who come to see me and say, hey Zoe, I checked myself in last week. What was going on? I was feeling very overwhelmed. There was a lot going on in the house. I could feel I wasn't sleeping for like 3 days. So I went over to IOL. I stayed for a week. They kind of sorted my meds out and I'm in a better place now. Voluntary. These patients are considered competent. They have the right to refuse treatment, and they maintain all their civil rights. Patients can also have a temporary emergency admission. Say that patient last week that told me she was suicidal with a plan and intent was in my office, then we'll probably send her out by emergency services to a local hospital. Oh, someone's hand was up. I missed that.
I just did that. I didn't want to interrupt what you were saying, but I wanted to acknowledge that I wanted to ask a question.
Yes, go ahead.
The patient that voluntarily admits themselves into a facility, if once they're there, they decide, you know what, I came here under one kind of thought process, and now I want to leave. Are they allowed to leave, or do they have to complete whatever treatment the facility deems that they need? If they wanted the patient to stay for a week, and the patient's like, I no longer want to stay here. I want to leave. Do they have the right to just leave?
That patient has, from my experience, the patient has the right to leave, but it depends on what factors. Okay, did they check themselves in saying, I'm having suicidal thoughts and now I want to leave? Or did they check themselves in saying, I'm having thoughts of hurting someone else and now they want to leave? So it depends on what premise they want to leave under, because if it's a risk of safety to themselves or others, then other things may go into play to keep them there a little longer for their own safety or for the safety of someone else. Does that answer your question?
Yes, thank you.
Yeah, but outside of that, they check themselves in, they're free to go too. So if I send this patient out by emergency services to the area hospital, she would have been typically held there for 72 hours, and she undergoes an assessment. And I can tell you sometimes it's even shorter, because mental health patients, they don't, it's like 6 to 1 half dozen of the other. Some patients will tell you, I like being in the hospital, but it depends on the patient. It is the patient who's homeless with zero supports, cannot find food, and that patient will like the hospital-like settings. And you can understand why, yes? Because when they're there, their needs are being met. I'm sorry? Yes.
Just answering, yes.
Yes. And then you have some patients who do not like to be in hospitalized settings, because even for some patients, mental health hospitalizations is a source of trauma for them. It could be the experience with other mental health patients, or sometimes it could be from their own experience. So sometimes they will come to see me and they will tell me, like one patient came and told me once, I'm going to go home and kill my boyfriend. I had to send her out. She has homicidal thoughts. I can't say she won't do it, so I err on the side of caution. I send her over. So she gets over to an area hospital. I don't know what Zoe's talking about. I never said those words. So after they do a thorough assessment, they let her go the same day, because she's not endorsing any of those things that she had mentioned to me. But I did due diligence. She mentioned it to me. I sent her off. They did due diligence. They assessed her thoroughly. She's denying homicidal, suicidal. She's denying everything. So they sent her out. They sent her back out. So, but typically it's a 72 hours old, where they are assessed by a psych team, psychiatrist even. Sometimes they'll call back whoever sent them in to say what was happening, how did they present, why did you send them in, and a decision is made about their care. Sometimes they get transferred over to a longer stay, like to IOL or to some inpatient somewhere else, but the decision is made usually within those 72 hours. It could also be an involuntary admission, as in made by a court, where they're held for a certain amount of days because they need to be inpatient to receive the treatment that they need. Or it could be like a long-term involuntary admission, such as like CVH, which is a state mental hospital where patients are there sometimes years on end. It's court ordered. Selena?
I have a question. So temporary emergency admission would be more like clinical admission, and then involuntary would be more like the court? Or can they interchange too?
It sounds muffled. Can you repeat?
Oh, I'm sorry. I said temporary emergency admission. Is that only with clinical? Like, could only APRNs and doctors do that, or can the court do that? Just like involuntary could be, is it only court, or can also clinical?
Well,
Like, is it interchangeable?
as it denotes emergency. So what setting would they be in when that emergency admission is deemed necessary? So it would pretty much be no, I changed the battery by now. It's not the battery. That was the first thing I did. I recently moved. I've been here only a few months. And I changed the battery. It's not just this one, it's the one upstairs too. I changed the battery and still it's not. So I have an electrician coming to look at it. I wish it was the battery. I would have taken care of that a long time ago. So back to you, Zalima. So you're asking if a temporary emergency admission is can it be the court or like an APRN or physician? It's typically an APRN physician, can be a police officer too, or sometimes it's even like a social worker.
Okay.
Because unless they presented in court for a court case and while they were there, they went berserk in court, then the judge can say, you know what, send them off. So it could be from a court to, depending on how the issue is presented, and where and when.
Okay, and then involuntary, would that just be the court, or could that one also be APRN or physician?
So it could be physician. Because sometimes they do go kicking and screaming. It's not always typical that they're saying, oh yeah, I need the help, let me go with you. So it could be involuntary if they're deemed a risk to themselves or others, depending on what the threat is. And the decision is made that they need to be inpatient.
Okay, thank you.
You're welcome. Effective therapeutic communication. So therapeutic communication is something that you're not new to either. I'm sure you've been learning how to talk to your patients since you started nursing school. But effective therapeutic communication is of a lot of importance when it involves mental health patients. Because these patients, they look at everything you say, everything you do. These are patients who have been through probably a lot of other healthcare settings, and they want to make sure that they're engaging with someone who is invested in their care. And that is why you have to put an extra effort into communicating with patients with mental health disorders. So active listening is super important. When I have my engagements with my patients and they walk in and I'm like, hey, what brings you here today? Or how have you been doing? If I just listen in the first 10, 15 minutes of them just unloading, I most times get all the information I need for my appointment. Because they will, oh, well, you want to see Zoe? I've been feeling really depressed lately. I broke up with my boyfriend, and because of that, things at work are not going so well. I really wasn't taking the pills every day because I was feeling sad after the breakup, but I'm going to start taking them every day soon. And since I stopped taking the pills, I'm not sleeping. I'm really not eating as much. I missed a few days of work the other day, and it looks like my boss is going to fire me. But I'm not having the thoughts of killing myself, though. No, I wouldn't kill myself. I did start smoking a little bit more, though. So just allowing the person to unleash very often, you get a lot of information just by listening actively. Sometimes silence speaks volumes, and I used to hear that, and I've come to realize that in this field of work, it is pretty important to just be able to listen. Asking open-ended questions, you know the value of that. You're nursing, you handle your nursing students. If you ask a yes-no question, you're going to get a yes-no answer. Are you feeling sad? Yes. Are you feeling depressed? Yes. But open-ended questions. Can you tell me why you're having these feelings? Did something happen why you feel this way? Can you explain to me what feeling sad means? So you ask those questions to elicit more information. Ask your information-seeking questions. You want to reorient the patient to reality. If this patient is having delusions, if this patient is saying they're hearing voices, seeing things, I understand you're saying you're seeing shadows on the wall, but I do not see shadows on the wall. You want to make sure you're not confrontational. There are no shadows on the wall because then the patient is going to get what? Defensive, right? So you want to make sure you're not getting into a power struggle with the patient either. You want to restate what they say. I pretty much always say, if I understand clearly, you're saying that you feel depressed and you're feeling depressed because you had a breakup with your boyfriend last week. Yes, because sometimes they will say things and it doesn't come across the way they intended to say it. So restating and clarifying is very important to appropriate care. Also validate your feelings. I can understand why you would feel sad. A breakup is a very stressful thing to go through. Validate your feelings. State your observations. But I notice as you're talking to me, I can see that your leg is shaking. Are you feeling anxious? Oh no, there's something crawling up my leg. Or yes, I have actually been feeling anxious as well. So you state your observations, or is it the patient that's telling you everything is okay? But I noticed that you look very sad, or your face looks not so happy. So you want to make sure you're also stating what you're observing, because sometimes what you're observing is not always what the patient is stating. And then of course you want to explore so you can get more information. You want to seek the patient's description of their feelings. Don't assume. I know what depression is. I know what anxiety is. And for every patient that tells me they feel depressed and anxious, I say to them, can you explain that to me? Can you tell me what it means to be depressed? And some of them will get very irritable. You know what depression is, but I want it in your words. Is this the patient that's telling me I feel depressed, and when I ask them, can you tell me what depression is? I don't want to talk to my girlfriend anymore. And I'm saying this because these are answers I get. So is this person in fact depressed, or are they upset? So you want a clarification of what they say they're experiencing. Look for patterns and themes. Is this the patient that tells you, I get depressed? I heard this twice yesterday. I get depressed every year around this time. The time changes coming up this weekend, and they have seasonal affective disorder. Sometimes it's self-diagnosed, and they tell me I'm going to be depressed for the next few months. Or is it the anniversary of someone's death? Is it the time of year when they had that horrible car accident where their friend died in? So it's very important to get patterns and themes as well. You want to read? Yes.
Sorry, quick question. So, I know you're using the word depressed in the example. And if we encounter patients that are saying, okay, I'm depressed, and then they describe something that's not, I guess, clinically the definition of depression, would you just use sort of like, I guess, quotes in your noting to say, okay, the patient said this, but this is actually what's going on? Would you, I guess, correct it on your end, but not correct the patient? Is that appropriate?
So sometimes the patient, back to my example, I'm feeling depressed. Oh, I can't sleep. This is a very common one. I can't sleep. I'm walking around a lot. I'm restless. I'm thinking about everything that's going on in my life. So, Mr. Jones, it kind of sounds like you're anxious. Do you feel anxious? Oh yeah, that's what it is. I'm anxious. So I could take that approach. Or sometimes I'll be like, it sounds like you're anxious. Oh no, I'm depressed. And I'll put in my note, patient endorses symptoms of depression, further described as, and I put it in quotes what they describe it as. Because for them, sometimes it is what they see it or what they think it is. Answers your question?
Yeah, that's great. And I think I was just more wondering, because I worked as a case manager, and people, I don't know all of the correct terms, but I know sometimes that patients will say one thing that as a professional that what they're describing isn't, I don't want to say accurate, but it's what they feel. So you want to, like you said, validate their feelings. But I guess in my notes, I'll say that the person said they're depressed, but they're really describing this.
Yes, I definitely put that in quotes. I most certainly do. I put verbatim in quotes.
Okay.
You want to reinforce healthy behaviors. Is this the patient that tells you, since I started feeling depressed, I re-enrolled in the gym, I'm eating, I'm trying to go to bed every night? Oh, those are very good choices. You're making healthy choices, which can also play into a healthier mental state. So you want to reinforce those healthy behaviors. You want to avoid self-disclosures. Sometimes self-disclosures can be appropriate. It depends on the setting and what it is that needs to be shared at that time. But generally speaking, you want to avoid making self-disclosures, especially something that, make sure it's not anything you're saying to the patient, I'm saying this to you, don't say this to anybody else, or make sure you keep this confidential. Make sure it's nothing like that you're sharing with the patient, and try to make it as general as possible, because very often patients, and I'm saying this from experience, it can come back to haunt you. So just be very careful about how much you share, especially as it relates to personal information. A lot of patients will ask me, are you married? You're dating? How many kids you have? Yes, I have children, and that's it. We don't need to get into the ages, the sex, how many. I'm a mother, so I can understand what you feel as a mother. Do not make assumptions. Do not assume that you know what the patient is feeling. Do not assume that you know what the patient is going to say. That's why you always restate, clarify, and get their understanding of what it is. I already mentioned the importance of sitting in silence, and of most importance, it's the importance of setting boundaries. So mental health patients don't always run around looking crazy. Sometimes mental health patients, like the patient who is has a borderline personality, will have inappropriate, how should I say, inappropriately friendly. So this is the patient who would probably want to bring you things or ask you for things, asking for hugs. So make sure you're setting those boundaries, and make sure those boundaries are consistent across the board for all patients, okay? It's very easy, very, very easy to get those lines blurred. And I must say, it's hard sometimes working with people and making connections and trying to be hard and fast. Like, I especially have the problem with my older Hispanic, older African American patients. They come in for their appointments and they're like, hey, Ms. Ortiz, nice to see you. I'll see you in 3 weeks or in 4 weeks. And I'm extending my arm for a handshake, and they'll grab me. Oh, get over here. And they're hugging, kissing my cheek. I'm like, oh, Jesus Christ. Like, and do I then push them away aggressively? No, you can't do this. I'm like, I would prefer we maintain a handshake. It's more professional. Yeah, I understand, Zoe. And it doesn't happen again. So it plays a lot into how you address it, how you deal with it. But boundaries are very, very important. Miss Ortiz's daughter just died, and Miss Ortiz was in my office crying. It's okay if I put my arms around you and she okays it, then it's fine. It's an embrace of comfort at that time, but not just for the run of the mill happy-go-lucky, we're hugging and touching all the time. No. So keep your boundaries, especially if you work with children. I've worked with children in mental health settings, and you come in, they want to run, they want to hug. It gets a little harder, but try to remember to remain professional at all times. Don't give false reassurances. Don't tell the patient, oh, once you take this pill, you'll be fine. Everything's going to work out just perfect. You can tell the patient what the med is prescribed for. You can tell them about its intended target. But don't give false reassurances, because when it doesn't work out that way, they're coming to find you. You told me that. Ineffective communication as well, not listening. If you ask a question, give time for a response. Do not minimize a patient's problems. What may seem insignificant to you may mean the world to someone else. I had a patient come into my office one day. She was actually losing it, in a panic attack, upset. And when I asked my questions and got to the bottom of it and to find out what was going on that could have caused her to be feeling like this, she shared with me that her baby father's girlfriend was calling her phone and she was calling her phone back, and they were calling each other back and forth to say, stop calling my phone. Then you call my phone first. No, I call yours. No, you're calling my phone first. And I'm in my head, I'm like, are you kidding me? But could I even let the patient know that's how I was viewing her stressor at the time? Absolutely not. I had to empathize with her and help her work through her feelings. So I say this to say, sometimes it may seem very silly in your eyes, but to this patient, this is the biggest thing happening in their life right now. Be careful how you give advice. Make sure it's not advice that's coming from your great grandma or grandma, as my grandma said. In your professional role, make sure your advice is empirical data that's been tried and true and tested in the medical field. Do not feed into the patient's hallucinations. Try to reorient them, redirect them. Again, don't confront them. Changing the subject is a big issue. Sometimes they want to talk about their son that died, but you really need to get that assessment done. And I'm faced with this problem all the time. I need to get this done and you want to talk about this. So sometimes I have to listen, and then I have to put in my note, patient spoke at length about son's death. This tells me this is something they're struggling with, wasn't able to complete assessment. Or very often I'll just wait for a little opening, maybe they pause, and I'll be like, can you tell me how you're sleeping? And I'll get my questions in, and most times I'm able to get my assessment, but sometimes the patient will get very offended or upset if you change the subject. Again, don't belittle feelings, don't criticize or be judgmental, and again, avoid self-disclosures. And I am going to take a break here before we start defense mechanisms. So it is 10:02. I will see you in 15 minutes.
Thank you. See you then.
Okay.